Can everyone see the slide? Can everyone?
Yes, Doc.
Okay. Okay, so shall we proceed now? So we will just do this slowly at our own pace. No need to rush. So I will be marking the bipolar limb leads now. So with the red. So this is the bipolar limb lead 1. This is bipolar limb lead 2. And this is bipolar limb lead 3. So far, so good. Okay lang?
Yes, Doc.
Yes, Doc.
Okay. So if you try to see the bipolar limb leads, each of them has a corresponding arrow or an arrowhead, right?
Yes,
So the
Doc.
arrowhead of lead 1 is this one. The arrowhead of lead 2 is this one. The arrowhead of lead 3 is this one. So what does that tell us? So opposite of the arrowhead is the negative electrode, positive of where the arrowhead is, that's the positive side. Since this is bipolar, so there's a negative and there's a positive. Everyone follows?
Yes, Doc.
Yes, Doc.
Okay. This one is the right arm. This one is the left arm. And this one is the LL. What is LL? Left,
Left leg, Doc.
left leg.
Left leg.
Okay. So any questions or shall we proceed? Proceed ta?
Proceed.
Okay.
Yes.
Okay. So if you try to imagine the Einthoven's triangle and the heart. So I will be drawing a representation of the heart with this blue color. So it is a conical organ with a tapered apex and a wide base. Yes. So this is the apex of the heart, the tapered portion. The tapered portion, when viewed antero-posteriorly, it appears this way. Follow? However, for the purposes of this representation, we'll just do with this one. So we all know the ventricles are here. Follow?
Yes, Doc.
The green area is the ventricle. So this is the this is the left ventricle. Since the heart is rotated in our chest cavity uh, posteriorly, what we can appreciate anteriorly is the left ventricle and a little bit of the right ventricle, but a big portion, a large portion of the right ventricle is uh, behind. Do you follow? So for the purposes of this discussion, this is just a uh, schematic representation of the heart. So this being the left ventricle and this being the right ventricle. Okay, follow? Then this is the right atrium, then the atrial septum and the left atrium. You follow?
Yes, Doc.
Okay. So looking at this graphic, looking at this representation, We'll just imagine that the heart is here in the middle. Okay? So let me do this. So the heart is this one. This is the heart. Okay. So for a quick review, I would like to ask everybody or anybody from the group, since we are dealing now, we are discussing first the limb leads, no? So when we discuss limb leads, we are uh, considering spatial position of the heart in the vertical plane. So when you say vertical, it's either superior and what's the opposite of
inferior.
superior? Inferior. So meaning it's either superior up or it's either down. Okay. So far, so good. Clear? Is it
Yes, Doc.
okay? Is the message clear? Okay. So looking at these leads, uh, lead 1, lead 2, lead 3, ABR, ABL, and ABF. What do you think? What leads uh, roughly what leads roughly placed in the apex or in the ventricle or in the inferior portion of the heart? So you have there
Three
lead
ABF,
2, lead
three AB.
3, and ABF. Nah,
Yes,
is this clear? So you don't need to memorize any book. You just imagine this Einthoven's triangle. So if you imagine this one, you can facilitate easy recall with this illustration. Okay? So talking about lead 1 and AVL, what is this one?
lateral.
So we are dealing with superior and inferior. So lead 1 and ABL roughly
Superior lateral.
represents the superior portion of the heart, mainly mostly the left atrium and a little bit of the right atrium. Follow? Left atrium, no? Superior portion, left atrium, and a little bit or a bit of the right atrium. Okay. Can we proceed?
Yes, Doc.
So once again, inferior portion is encompassed by lead 2, lead 3, and ABF. Superior portion is represented by lead 1 and AVL. So that is very easy. So you don't need to be stressed with this one. Follow, Ra?
Yes, Doc.
Okay. Now, uh, what's this one? I would just like to say to everyone, any ECG changes in lead 2 or lead 3 or ABF must be contiguous. What do I mean contiguous, continuous? It must be seen on all of these three leads. Okay? For example, if you see an ST segment elevation in lead 2 and lead 3, what does ST segment elevation signify? So it signifies a probable infarct or a probable probable myocardial injury, right?
Yes, Doc.
So for it to be significant, it must be found in this particular ST segment elevation. Just in case you see an ECG, it must be seen in lead ABF, in lead 3, and in lead 2 for us to conclude that it involves the inferior wall. Falora,
Yes, sir.
is it clear? Okay, so what do I mean by this? So it must follow the all or none principle or the all or none law. So for us to conclude that there is an probable infarct in the inferior wall, we must see on all the contiguous leads, namely lead 2, lead 3, and ABF, an ST elevation. Okay? If we only see an ST elevation in ABF, what will be our conclusion? Is it significant or not significant?
Not significant, Doc.
Very good. Why?
Not contiguous, Doc.
Very
All
good.
or none.
Okay. So is the message clear?
Yes,
So
doc.
why are we doing this? So I'm just giving you a brief overview since we will be dissecting the subsequent ECG tracing of the case. Okay? Does everybody wants this process flow, or do you want any, or do you suggest any other?
Proceed, Doc.
Okay, proceed. Yes, thank you. So what goes below, same, it occurs above. Okay, so if you see ST segment elevation in lead 1, what does that tell you? However, AVL is, there is none. So we still follow the all or none principle. So that ST elevation appreciated in lead 1 is not significant. Okay, when do we say again it is significant? The ST elevation or the ST depression must be present in
All
both
the
of,
contiguous leads.
yes, contiguous leads. So contiguous leads meaning they are adjacent with each other, right?
Yes, doc.
Okay, shall we proceed? Is it clear, or are there any questions before we move along?
Clear kayo, Doc.
Clear kayo. Bantay ha. I'm just kidding. So try to just, so when you are given an ECG, please always go back to this drawing, no? So this illustration is very important. That is all I have to say about this one. Okay, so let's proceed. So what are we missing?
AVR, Doc.
AVR. Okay, for now, let's set AVR to the side for now. Aside from AVR, what are we missing? We are missing the
Recordia leads.
precordial leads. So I am drawing here a representation of the thorax. No? Follow? Does everyone follow? Or this, the
Yes,
heart
Doc.
is too large. I'm sorry. Again. Let's do this again. So this is the heart. Again. I'm sorry. Okay, this is much better. So just try to imagine, visualize this is the anterior thorax, and the heart is found in the middle, or the mediastinum, right? Okay, so we will proceed. Ideally, where do we put the
V1, Doc.
V1? Yes.
Fourth right intercostal space, Doc. Substernal border.
Okay. Hold on ha. Just imagine na lang ha. So, fourth intercostal
Space, Doc.
space,
Right sternal border.
right sternal border. So, this is the sternum. So, what is the anatomic landmark which corresponds to the fourth intercostal space in most individuals?
Mabra siya nipple line, Doc.
Nipple line mostly. To be more accurate, so nipple line is correct. But however, due to variations in subcutaneous tissue, right? In the mammary glands, in subcutaneous fat, due to normal variations in each individual, a more reliable landmark would be the second intercostal space. So what would be what area of the sternum corresponds to the second intercostal space?
Angle of Lewis ba na, Doc?
The sternal angle of Lewis, no? So you have three parts of the sternum. So the head of the sternum, the what do you call that one? The manubrium sternae, the corpus sternae, and the xiphoid, no? The three parts of the sternum. So the angle of Lewis is the junction of the head and the corpus sternae, no? Right?
Yes, Doc.
So this will be the imagine this one. The red part is the second intercostal space. Beneath the second intercostal space is the third
Third
rib. Beneath the third rib is the
third
third
ICS.
ICS.
ICS. Okay. Beneath the third ICS is the
Fourth rib.
Rib.
fourth rib. Beneath the fourth rib is the fourth
Fourth
ICS.
ICS.
So V1 is placed where? Fourth intercostal space,
Right sternal border.
right sternal border. So this will be V1. Hello? V1. So V1 is here. Follow, ra? So nipple. Okay. So how about V2?
Opposite side, Doc.
Left ra, Doc.
Left. Left what?
Fourth intercostal border, Doc. Left
Okay.
sternal border.
So this will be V2. Clear, ah? Shall we proceed? Proceed, ta?
Yes, Doc.
Okay. So I'll do it all over again. I'm sorry. So V1, V2. Again, how about V4? Where do we place V4?
The fifth intercostal space, left midclavicular line.
So fifth intercostal space, mid clavicular line. So at this point, Follow?
Yes.
Yes.
How about V3?
Midway, Doc, of V2 and V4.
Very good. So V3. Does everyone follow? So mid-clavicular line. Shall we proceed? So V5, where do we put V5?
Dili pa, Doc. V6 pa, Doc.
We can proceed with V5. So where do
Okay
we
na
put
lang.
V5?
Intercostal space left anterior auxiliary line.
Anterior axillary
Auxiliary line.
line. Okay. So this one? Follow? V6 is still on the left side. Okay. Left.
Post.
Left mid axillary.
Mid-axillary.
So same level as V5, but in the mid axillary line. So is the illustration all right with everyone?
Yes, Doc.
Yes, Doc.
So the limb leads deal with superior and inferior, right?
Yes, Doc.
The precordial leads deal with
Anterior, posterior, Doc.
very
Horizontal
good
plane.
horizontal plane, anterior and posterior. So please do not forget that one. Sige. So for moving on, V1 and V2 represents the mostly both of the atrium, right? Correct?
Yes, Doc.
Okay. So anterior portion, the left and the right atrium. V3 and V4 represents majority of the left
Ventricle.
ventricle, so anterior, right? Behind the left ventricle, rotated posteriorly is the right ventricle. Tama? So V5 and V6 represents
Right vent.
so a little bit of the left ventricle and a portion of the right ventricle. So it is very not so clear, not it is ambiguous or equivocal. However, since it is placed at the sides, we can label it as lateral portion, right? So if you have observed, we have encircled V1 and V2. So what does that mean? These two leads are considered contiguous. Therefore, they follow the
All or
same
none.
None.
all or none law. So any changes in V1 for it to be significant must be seen in V2, right?
Yes, Doc.
Any
Yes, Doc.
changes in V4 for it to be significant must also be appreciated in V3 for it to be significant, and V5 and V6 as well. So they go in pairs, right?
Yes, Doc.
So far, so good.
Yes,
Klaro
Doc.
kayo, Doc.
So no need to memorize the numbers. You have a table there in the book. So that will consume acetylcholine when you memorize that one. So that will consume neurotransmitters. Instead, just imagine this illustration or this drawing and you will be safe. So can we proceed now?
Yes,
Doc.
Doc.
Okay. Any questions?
Wala pa, Doc. Wala
Wala
none
pa?
so far. None so far.
Okay, thank you. Thank you. Another important aspect of this one, so is position. So, okay. If this is 0 degrees, this will be do you follow?
Yes,
Yes,
Doc.
Doc.
90 degrees. When you try to use your protractor, right? When you measure angles. So the opposite of 0 is
180.
180 and all the way is
360.
because it's a circle, right? Okay, for the purposes of this discussion, to make life easy, again, we always go back to the heart. Okay, follow, Ra?
Yes, Doc.
Where does the initial depolarization arise from?
SA node, Doc.
So SA node. So where is the SA node found?
RA.
So in the
RA.
interatrial septum, close proximity to the right
Yeah.
atrium, right? So this is the location of the SA node, the one with the blue dot. Do you follow?
Yes, Doc.
Okay.
Yes, Doc.
The impulse travels along the SA node, the depolarization to stimulate the right atrium and the left atrium, right?
Yes, Doc.
Denoted by these yellow lines. So the impulse travels all around the muscle fiber. Some of the impulse goes down and stops briefly at the, what do you call this portion?
AV node, Doc.
No.
AV node. So the AV node is there to momentarily stop the impulse from the SA node to allow the right atrium to contract and spare the ventricle, right?
Yes, Doc.
So the purpose there is so that they will not be contracting simultaneously, right?
Yes, Doc.
So it contracts in a rhythm, atrial, ventricle contractions. They do not contract simultaneously. The atrium and the ventricle is made by God not to contract simultaneously, so that what will happen if they contract simultaneously? There is no filling of blood in all the chambers. Therefore, it will be an ineffective pump, right?
Yes, Doc.
Okay. So if the atrium contracts, it will pump blood to the ventricles. Then the atrium relaxes. It is now the turn of the ventricles to contract, propelling the blood to the pulmonary vein and the for the right side and the aorta for the left side, right? Tama ba? Does everyone
Yes.
follow?
Yes, Doc.
Okay. I'm sorry, pulmonary artery. since it is unoxygenated blood from the right ventricle. Okay, so shall we move on?
Yes,
Yes.
Doc.
So moving on from the AV node, I'm sorry, from the AV node here, the electrical impulse travels to the interventricular septum, right? Stimulating the muscle fibers, transmitting the impulse to the left ventricle and the right ventricle. Okay? So the bundle of His and the Purkinje
In the fibers.
fibers. Okay. So as we are dealing with impulses or depolarization, there is a negative and there is a positive side, right? So what the electrodes do, that the things that are placed on the anterior thoracic cavity, they measure the generated impulse, right? They measure the generated potentials. Do you follow?
Yes, Doc.
Okay. So going back, the SA node, so when it depolarizes, impulses are generated all around, right? However, a vast sum or majority of the impulse goes down to the AV node, ha? Follow, ra?
Yes,
However,
Doc.
these impulses, there are minor impulses that go down, that go all around. However, majority, a vast number of the impulses goes to the AV node. Then from the AV node, a vast number impulses are generated all around. However, a vast number of impulses goes down along along the path or the track of the interventricular septum. Okay? Do you follow?
Yes, Doc.
Any questions?
None, Doc.
None. So it is the purpose of the ECG to measure this one. The purpose of the ECG is to measure this one. So we call this
Axis.
the axis, okay? So in normally in individuals, the normal axis generated by the sum of all the negative and the sum of all the positive electrical potentials is located in this area in normal individuals in generally. So this shaded area is considered normal, okay? Which corresponds to negative 30-degree position, right? Negative 30 all the way to
100 degree.
so 100 or 110 degree. Okay? So when I ask you what is a normal, what is the normal axis of the heart, or where is the PMI or apex beat generally located? So your answer will be if it falls within negative 30 to 110 degree position, it is considered normal. Okay? Let's say in theory, you were able to measure the sum vector. The sum vector you have calculated or computed falls within 0 degrees. So is this normal or is this not normal?
Not normal na daw.
So it is normal because 0 falls within
The negative 30 to 110.
so where's 0? This one, right?
Yes, Doc.
So is 0 within the range of negative 30 to 110?
Yes,
Ano sa'yo,
Yes.
no?
Doc.
Sige. Iti-one imong grade. Kinsay gabot sa imong grade? Ma'am Joy? Dili si Dr. Maya. Later na ni ha. Later na. Ah. Ako lang ni permahandaan. Kompleto na ni ha. Dayon, complied ni tanan. Are you sure? Naa imuhang reflection paper? Sa unsa may nabuhatan nimong reflection paper? So, unsa man na siya nga program outcome nga reflection paper, ang strength weaknesses. So, what are your program outcomes for the Philippine College of Physicians? How many program outcomes? Agoy. Sige. I would like to ask for program outcome number 8. Kita ka? Nationalism, social advocacy, equity, and accountability. It states here complied and attended. I would like to ask what activity? Oh, medical missions. So please put what activity? Okay, so what's the output of the activity? So do you have a reflection paper? Can I see your reflection paper? Ato itanaw. That is the purpose of this one, so we can audit and determine what are lacking, so we will catch up. I will not sign this until I will see everything, ha? But however, I'm in a meeting. Can you come back 30 minutes? Ato tanaw. Like kani ha, I'm very particular about this one. Mini CAX, do you have your mini CAX documents? Oh, I need to see that one. Kanus ay imong renewal? Ha? Katong March pa. And then, what happened? So, nakuha sa research proposal. So, does one day make a difference if I sign this now? Dili na mo make a difference, no? Oh, so I want you to bring Naka tomorrow.
Ako lang ikaw kay kuan tomorrow
Oh,
with my portfolio na lang po.
dadatanan. Oh, the purpose of this one is a portfolio, ha? Oh, it used to be before I sign. However, inig-abot sa third year, inig-audit na to. Daghan kay kulang. So that is why sa first year pa lang, we should do this right the proper way. And I mean, we do it the proper way, the correct way. Dili anang urada-urada, ambush-ambush, papirma kay lisod kaayo niya. You will suffer in the end, in the third year, maglisod ta o kuan mo ni ato tagsa-tagsaon. This is audit na lang pod like this one. Kani siya mo common like this one. Program outcome number 5, no? So workplace performance is
Ang MSF na
you can use MSF. So if I ask you what are your sources for your multi-source feedback?
kuan na po doc is resident nurse o kuan
Okay.
kuan na po doc
Where did you have that one? Resident, co-residents or nurses in the
words
ward? Okay.
niya ang isa doc si ang among senior.
Okay. So can I see the multi-source feedback? So i-bring ha. Kaya ato tagsa-tagsaon para wala na kulang. So okay. Like this one. Program outcome number 6. Systems-based approach to healthcare practice. So it states here you have complied and attended okay. So what activities were conducted for this particular outcome?
Isa is mga conference doc o katong mga ano doc na video loading sa ECG tracing
ECG tracing. So that is kuha na siya. That is program outcome number clinical competence.
yes doc napod ko sa ECG po doc.
Okay. So for this one, unsa may activity gibuhat? Lecture sa Harrison. Lecture sa Harrison is it states here nga complied man. Muna ato tanawon kay that is evidence. Okay? Wala ti ka gilisod-lisod ha. Pero I want to do it correctly good. Ha? Na-follow ra nimo? Okay. But I will sign this. But if I cannot review your paper, dili ko mulingkod sa interview nimo ha. Okay? Para di na ka magkalisod. Pero I need to see ha. Okay. Sige, sige. Imong research.
Done for research proposal doc.
Okay. This needs to be signed by
Doc sa co-author na ko doc.
no. Research coordinator. This needs to be signed by him. Kani siya. Kay ato ni siya iscan.
Yes.
If everything, if all the record is sufficient, we will scan this and have this outputted as PDF.
PDF.
We will send this to the PCP. Pero we want to make this correct. So this needs to be signed by Dr. Cañizares. All right? Sige. So I signed here. I'm not trying to make life hard for you, pero dapat comply ha, ato i-audit ha. Then kung unsay kuwang, atong trabahoon ha. Okay. Sige, sige.
Anteriorly, that's the left ventricle. Okay? Can you imagine what I'm saying? The one anterior to your chest
Oh, kani.
is your left ventricle.
For the OPD, you have to specify unsa may gibuhat nimo sa OPD, actual physical contact OPD or teleconsult.
Ang both dito. Pwede specify lang na ba dito.
Oh, specify here teleconsult how many weeks and what is the time interval.
Yes.
Okay, this will be hard if you put here January 2020 to January 2021. So,
Specify na ba
wala ba ta nag-OPD for 52 weeks. So, make the necessary corrections. Ha? Okay? Sige. Unsa pa lain question?
Ang words lang dahil dok is. Ito lang.
Oh, so make the necessary correction, especially the OPD, ha?
Yes.
Oh, okay. Kita ta ugma ha. Come back here unsa oras man. Kay na man interview. Early lang siguro, mga 8, 8:30, ha? Yeah, bring the documents ato i-audit, ha?
Yes.
Okay, sige. Thank you. Isabit na nimo sa Petro, ha? Pero please make a separate copy para ma-scan nato, ma-send nato sa PCP, ha?
Yes.
Okay? Sige. Okay, I'm sorry. Where were we?
Sa normal axis, Doc.
Okay, normal axis. Let's say the axis is kani sakto 0. Is that normal or abnormal?
Normal daw.
Normal ra. Okay? Let's say you were able to determine the axis plus 50. Is this normal or is not normal?
Normal daw.
Normal. So you understand now? So how to compute the axis, we will also tackle that later. Perhaps this Thursday, ha? Okay? Maka-remember pa mo how to compute for the axis?
90 AV, 90 AVF over. Kalimutan ko, Doc.
Okay. So it's all right. We are here to learn. You're here to learn from me and I'm here to learn from you as well. So it is the consensus of the group nga that everyone has forgotten, right?
Yes, Doc.
Yes.
Sila lang kami, Doc.
So we will review this one. How about the rest of the team? Is that a yes?
Yes.
Yes, doc.
Yes. All right. So we will do that. So far, are we still okay? Or is everyone falling
Okay
asleep?
pa daw. Okay pa daw.
So what's the normal axis again?
Negative 30 to
110 degree.
Okay. What if there is an ST elevation in V1, V2, V3, and V4? So what does that tell us? What portion of the heart?
sa ganito daw. V1.
If there is a ST depression in V1, ST depression is consistent with ischemic changes. Okay? So what if there is an ST depression seen in V1, V2, V3, V4, and V5?
Anterior daw.
Anterior,
Anterior wall.
anterior wall. So the entire anterior wall, right? Why?
Base sa precordial leads daw.
Base of precordial leads, no? It involves the atrium as well as majority of the ventricles, the left ventricle, right? So V1 man and V2, di ba? So V3 and V4. So what if there is an ST depression noted only in V1, V2, and V3?
More on sa atrium lang siya, Doc.
So more on sa atrium lang, no? So V3 is not ST elevation is noted, however, ST depression is noted. However, it is not significant since it is only seen in V3. Na-follow ninyo?
Yes, Doc.
Okay. So V1 and V2 ray i-consider. So interatrial wall, right? Or the atrial walls. Na-follow?
Yes,
V1
Doc.
and V2 man. Okay. So clear, ah?
Yes.
Kayo, Doc.
Okay. Proceed ta? Okay. So we are going to proceed. Di, tanaw na ko, basi nangatulog na ni. Is everybody still awake? Okay. Okay. So with the ECG, so this is the ECG. So we will try to correlate. This is the ECG. Asa ganito. This one. Everybody sees this?
Yes.
Okay. So let us check first the axis. Oh, later na day ang axis. That's for Thursday. So let us check first the morphology of the P, the QRS, the ST segment, and the T wave, right? Okay?
Yes, Doc.
Okay. Please hold on. So this will be your assignment. Does everyone have a copy of this ECG or a screenshot?
Yes, no.
Yes, okay. Sige. So I can draw on it freely. Sige. So let us say this is a representation of the ECG. So this is the P wave. Okay. This is the Q wave, the R wave, the S wave, and the T wave. Follow ra?
Yes, Doc.
Okay. So any questions? The P is supposed to be small, ha? This one, let me edit para klaro siya. So the P is supposed to be small. Ana. Okay, much better.
Yes, no.
So this one is the P wave. Okay ra? This one is the Q wave. This one up to this one going up is the R wave. This one up to here going down is the
S.
S wave. Okay. And this one finally is the
T wave.
okay. Any questions? Or
None, Doc.
we want to do this again? Okay na? Okay. I would like to point out a very special portion of the ECG. So this point marked with the blue color. So this is what you call, what is this one?
J point, Doc.
Very good. Why is this very important? So this will determine if we have an ST depression or an ST elevation. Okay? This is the one marked with yellow is the iso.
Electric line.
Very good, is the isoelectric line. So naka-remember pa mo sa lecture? So the isoelectric line, okay? So if the J point falls within the isoelectric line, that is, what is that?
Normal.
Normal, very good. Okay. Okay. So we will try to do a schematic illustration of unsa may ato, what to do first, ST depression or ST elevation? What do you want?
Elevation na lang daw.
Elevation na lang. Okay. Okay. So again, as with all ECGs, so this is the P wave. This is the Q wave. This is the R wave. This is the S wave. So the T wave. So for this representation, this will be the, what is this again? The yellow one?
Isoelectric line, Doc.
This is the isoelectric line. Now I want you to focus on the J point. So this being the J point, do you follow?
Yes, Doc.
So if the J point is above the isoelectric line, what does that tell us?
ST elevation, Doc.
Okay. So this is a ST elevation. By the way, this is the T wave, huh? Follow? Any questions? You want to proceed?
Proceed, Doc.
Yes, Doc.
Okay. Okay. Kapoy, no? So this is the P wave. This is the Q wave. This is a R wave. This is the S wave. Again, this is the isoelectric line. You follow? Yes or no?
Yes,
Yes, Doc.
Okay. So this is the, what is this one?
T wave.
I want you to focus now on this one. What are we marking with the blue dot?
J point, Doc.
J point. So does anyone want to say something about the J point?
Depress, Doc. Lower. Baba.
Okay. Na-depress siya. The J point is not happy. Okay. So this is how a typical ST segment depression would appear. Okay. Is this clear? Are there any questions? Shall we proceed?
Let's proceed, Doc.
Is everyone tired? I'm tired. Bitaw.
Ang TV ninyo nabalik na.
Okay ra? Are you still good? Or this is too much?
Okay pa, Doc.
Okay pa? How about the others?
Okay pa, Doc.
Okay, okay pa. Okay. I want you now to see this one, no? It's very evident. So,
Dahilan.
this one.
Dahilan na sila kay masave
Okay.
mo. Kung imong pita-kwintahon, ako yun yung mahadlok
What is this one?
Kay wala sila hilas nila, wag sila vaccine. Dahilan na.
So this will be
Dahilan na ma kay alkan
V6, no? This is V6, right? The photo is a little bit blurry, but let's just say this is the V6, okay? So this is a particular, what can you say about this one? V6.
Mahadlok na sila. Dahilan na sila ma.
When you compare with lead 2,
alkansi ka. Kay wala din na sila
That's the elevation, Doc.
very good, no? Lead 2 appears normal.
Isoelectric na, Doc.
Oh, okay. This one is not normal, right?
Dahilan na sila. Bukid alkansi ka.
Do you understand? Does everyone get it? Why this is not normal?
Yes, Doc.
Yes, Doc.
Yes for everyone? Is it a yes or is there a no?
Yes, Doc.
Do not be embarrassed if it's a no. We will go back again. So it's a yes for everyone?
Yes, Doc.
Okay. Thank you.
Sige na lang na ma kay 5 to 7 days na bitaw kasi bubong ko test bitaw check balik sila
Okay. So
naglibang pas papawa.
this one I'm trying to point is the, what is this one? The very tiny.
Pero wala nang libang ron. Wala.
Can everybody see? P wave, the very small one, huh? This one.
Karon wala na.
Ano siya, ha?
Sige. Ay mo.
This one also is a P wave, right? This one is the
I'm lakaw sa wa pa mo no mag-quarantine.
P wave, right?
Ah.
This one is the
Basta yun.
P wave, right? Tama? Yes?
Yes, Doc.
Correct? Okay. Do you see
Sige.
Q waves on this one? Wala, no? Are there Q waves on this QRS complex? Yes or no? So none, okay? We cannot appreciate Q waves in this QRS complex, all right?
Yes, Doc.
Is the R wave present in the QRS complex?
Yes, Doc.
Okay. Is the S wave present in the QRS complex?
Yes, Doc.
Yes, Doc.
Is the T wave present in the
Yes, Doc.
QRS complex? Okay. In some QRS complexes, it is normal for a Q wave to be absent or not appreciated, like this one. There's no appreciated Q wave, but this is normal. Okay?
Wait 2 days.
Do you follow? Do I hear a yes or a no?
Balik ako. Tuon na ako.
Yes, Doc.
Yes, Doc.
Okay. Now, with this one, as with before, the one mark with the blue dot is what you call the
3 point.
J point. So the J point appears to be
Sa isolation center.
Elevated.
Okay. So na-follow ra ninyo?
Yes, Doc.
Okay. You understand now, finally?
Yes, Doc.
Okay. Hold on ha. Let me erase everything. Okay. Looking at this ECG now, where do you see the ST segment changes? It is found in... Okay, let's do it one by one. In lead 1, okay ra? Is it okay with lead 1?
Yes,
Yes.
Doc.
Yes, Doc.
Lead 2 is yes as well.
Yes, Doc.
Yes, Doc.
Lead 3, there's a little bit of ST depression
Depression.
in lead 3. Okay. Please make a note. In AVL, it appears okay. In ABF, it appears okay. In AVR, it is okay as well. We will discuss before we conclude this morning, why does AVR appear
Reverse.
this way? I forgot about this one. Anyway, moving on. How about V1? Is there an ST elevation in V1?
Yes, Doc.
Yes, Doc.
Yes, okay. So the J point. Okay, hold on. So what we have here for everyone to understand in V1 is there a Q wave?
Yes, Doc.
Okay. Is there an R wave
Di kaya
going
mo
up?
appreciate.
So,
Cannot be appreciated.
so this is the Q wave, this one in yellow. The R is the deflection, first deflection going up. So this is the R wave, okay? So the S wave is not really appreciated in V1, okay? So this is the Q, this is the R. Okay. The one marked by the blue dot will be our, what is this one? This will be the
3 point.
J point. So is the J point elevated?
Yes,
Yes,
Doc.
Doc.
Yes,
Okay.
Doc.
So it is the consensus of the group that there is a ST elevation in V1. How about V2?
Elevated.
Elevated, Doc.
Elevated, Doc.
Okay. So please make a note. So V1, V2. How about V3?
Elevated gyapon, Doc.
Elevated.
Okay, wonderful. How about V4? Very much
Yes, Doc.
elevated. Okay. How about V5?
Yes, Doc.
Elevated.
V6? Slight.
Slide.
Okay, V6 is this one. Just follow the line. There's a line here. Slight lang. Okay, so what does that tell us? Okay, finally, we're almost done. So there is an ST elevation in V1, V2, V3, V4, and V5. What does that tell us now?
Tissue damage, Doc, sa septal, anterior, and lateral, Doc.
Okay, so myocardial injury or tissue damage sa septal wall, anterior wall and the lateral wall. However, for the purposes of this discussion, we will not consider the ST elevation in V6 as significant. Okay? So given that one, we are given clear ST elevation in V1, V2, V3, V4, and V5. So what does that tell us again?
Septal and
Septal and anterior wall only. Okay? Is that clear for everyone?
Yes, Doc.
Okay. Sige. So my assignment now is this one. Oh, your assignment. I'm sorry, it's not my assignment. It's your assignment. We all know that in V6, there is a elevation of the J point. But what made us decide that this elevation is not significant, right? Let's look at it this way. What is the normal WBC count?
5,000 to 10,000.
5,000 to 10,000. For a patient who is well, who comes into your clinic bringing in a CBC result, the WBC count is 11. Is the WBC count result elevated or not?
Elevated, Doc.
Elevated. Very good, correct. However, is that significant? Patient is well, no fever.
No fever.
Yes, patient is well.
Dok kay correlate ni mo pud siya dok kay slightly elevated na pud siya.
Very good. So dili nimo patulan, di ba? Okay? So same as with this, in the context of this V6, it is true that the J point is slightly off the isoelectric point. Do I hear yes?
Yes, Doc.
But let us all agree for now that that J point elevation is not significant. So my assignment for you is one. What is a significant SJ point elevation? How many small squares for us to say that the J point is elevated, or how many millivolts? So this is very important. For a junior clerk, this is good to know. It is enough that you can identify ST elevation and ST depression. However, when it comes to this particular tracing, like what we see in V6, it is equivocal. We cannot decide, right? So therefore, we must be able to delineate, or we must be able, we must be armed with information. So what is a significant J point elevation in the limb bleeds, and what is a significant J point elevation in the precordial leads? So you try to read up on that one to find the answer. Okay? Okay na? So for this
Yes, Doc.
Thursday, we will continue. This Thursday, we will determine the say ato ang buhaton ining Thursday. We will determine the rate, how to get the atrial rate, and how to get the ventricular rate, right? This Thursday, we will review on how to get the PR, interval. Okay? This Thursday, we will determine the QRS interval. This Thursday, we will determine the QT interval. Okay? Na-follow
Should
ra?
we include the axis, Doc?
This Thursday, I'm sorry, I forgot. So we will review also how to determine the axis and the position of the impulse. Okay? Is that good?
Yes, Doc.
And we will finish this ECG once and for all. So we will be able to interpret the ECG. Okay. So off the bat, can anyone remember how to compute for the heart rate, the atrial rate? Wala na, forgotten all about it.
Heart rate, Doc, is equals to 1,500 over the small squares.
So number of small squares divided by 1,500 divided by the number of
Small
small squares.
square.
Correct. Okay. My next question is, where does that 1,500 come from? Some people use 300, right? So where does this come from? So that is another assignment. Assignment number second assignment, okay? Okay. So for Friday, if we can finish this on Thursday, we will have the presentation on Friday by our esteemed two members from yesterday who acted as the physician, right? Sakto, am I correct?
Yes,
Yes,
Doc.
Doc.
If we cannot finish on Thursday, let's continue on Friday. Then we will just try to squeeze on another date our presentation for this particular topic, cardio. Okay, since I find it a very necessary skill for students to easily correlate an ECG. ECG is a very commonly utilized diagnostic modality in the emergency room as well as in the ambulatory care. And it is a mandatory skill for junior clerk or a senior clerk to be equipped with information on how to process ECG. Okay? So we will see I'll see you on Thursday. So be ready with your assignments. So what is the first assignment?
Why the Doc, why V6 is not significant?
Okay. So you try to read up on that one. So what is a significant J point elevation in the limb lead, and how many millivolts does it need to for it to become significant in the limb lead as well as in the precordial leads. It's different from criteria for the limb leads from the precordial leads. Okay. Then
Yes, Doc.
assignment number 2 is where do we get the factor 1,500 and or the 300? Okay. So stop na ta. I'm tired. So is everyone okay? Any
Okay, Doc.
questions?
None, Doc.
With the AVR, we will tackle it briefly this Thursday. The AVR. Why is the AVR appear or seems opposite from the rest of his uh, uh, colleagues, right? Okay. So any questions,
None, Doc.
Andra? How about the others?
None, Doc.
None?
None, Doc.
Okay. Okay ra, clear as mud. Katawa man ka Suliano.
Clear as mud.
Clear as mud. Bitaw, I'm just kidding. Do not be embarrassed to interrupt the flow. We will accommodate any stragglers and shoot them on sight. Huh? Okay. I'm just kidding. Ha? We will accommodate everyone so that we will act as a cohesive unit and move as one single unit with this topic. So I assume everyone understood. So we'll just have a very, very quick review this Thursday and proceed with the agenda. Okay? Okay. Sige. Okay. Bye,
Thank you, Doc.
everyone. Okay.
Thank you,
Thank
Doc.
you.
Thank you,
Bye-bye.
Doc. Thank you, Doc.